If humans live long enough, everyone will eventually develop cancer. The current lifetime risk of getting cancer is over 40%, and dying from cancer is over 20%. Unfortunately, cancer affects the lives of millions of people all over the world, making it the second leading cause of death worldwide. Of all cancer types, pancreatic ductal adenocarcinoma is the fourth deadliest, with survival rates of lower than 10%, and most patients dying within the first year. The current treatments of pancreatic cancer include radiotherapy, surgery, and chemotherapy. Typically, surgery is the go-to treatment for pancreatic cancer. However, most patients are not even eligible for surgery. For those patients, a combination of chemotherapy and radiotherapy is usually administered to them, though both chemotherapy and radiotherapy suffer from normal tissue toxicity. So how do we overcome these problems? This is where the power of nanotechnology comes into play. Nanoparticles could be used in radiotherapy as radiosensitizers and in chemotherapy as drug carriers for a combined chemo-nano radiotherapy treatment. The idea here is that the small size of these nanoparticles would allow them to accumulate in the leaky, gappy tumor microenvironment as opposed to normal tissues. For our radiosensitizers, we use gold nanoparticles. In the presence of ionizing radiation and through photoelectric effect, gold nanoparticles can increase the production of free radicals, which in return increases the production or the accumulation of DNA double-strand break inside cancer cells, which eventually leads to cancer cells to die. But why are we using gold nanoparticles specifically? Gold nanoparticles have shown to have low toxicity. They could easily be produced using different chemical processes. They have an excellent surface chemistry, as they could be functionalized in a way to specifically target tumor cells. And also they're extremely versatile, as they have different applications in therapy as well as in imaging. On the other hand, Docetaxel is an FDA-approved drug that is being used today in the clinic for different types of cancers. It also happens to be a very good radiosensitizer. So it does radiosensitize cell by locking the cell in the most radiosensitive phase of the radiation cycle, or of the cell cycle. So when used with radiation, that adds a radiosensitizing effect. The mechanism of action of docetaxel, though, stems around changing the microtubule assembly inside cells. So what happens when we use gold nanoparticles with docetaxel at the same time? In a typical situation where we only use gold nanoparticles with no docetaxel, gold nanoparticles enter the cell via receptor-mediated endocytosis, and then they move along the microtubules, and then after a specific period of time, they get recycled, and then they leave the cell. When we use docetaxel with gold nanoparticles, because microtubules, which are like highways inside the cell, are damaged, this helps gold nanoparticles stay in the cell for a longer period of time. So using both docetaxel with gold nanoparticle increases the retention of gold nanoparticles inside cancer cells. However, docetaxel is toxic to normal tissues. As a matter of fact, only 0.1% of the drug reaches the tumor, while the rest of it goes to different places in the body. So how do we overcome this problem? Again, nanoparticles. We bioengineered lipid nanoparticles to encapsulate docetaxel in a hydrophobic pocket inside of them. These lipid nanoparticles are made of organic compounds that do not trigger the immune system. Also, their surface could be modified in a way to specifically target tumor cells. To further decrease the toxicity of docetaxel, we've created a prodrug docetaxel that is inactive, that gets active when uptaken by cancer cells. In this experiment, we created a 3D co-culture model made of cancer cells and cancer-associated fibroblasts to better represent the tumor microenvironment. This 3D model we're hoping that it would yield better results than the current models that are currently being used in different labs. And then we tested the combination of gold nanoparticles, radiotherapy, and lipid nanoparticles. We used clinically relevant doses, keeping in mind clinical translation in the future. What is the goal of all of this? The goal is to assess the combination of gold nanoparticles, lipid nanoparticles, and radiotherapy versus the current conventional radiotherapy doses being used in the clinic. The results were really promising. This triple combination caused a 39% increase in DNA double-strand break in cancer cells, as well as 28% decrease in the total tumor size. We think that these results could be translated into the clinic based on the doses that we used in vitro and in our 3D model in vitro. However, we also noticed that docetaxel, when used with gold nanoparticles and radiotherapy, yielded better results than using lipid nanoparticles with gold nanoparticles and radiotherapy. We think that the power of nanotechnology is more suited for an in vivo environment than in vitro environments. So therefore, in the future, we're planning to do an in vivo experiment using the same triple combination. In conclusion, despite the advancements in medicine, pancreatic cancer is still one of the deadliest types of cancers anyone could ever get. In this work, we tried to improve the in vitro model by creating a 3D co-culture model made of cancer cells and cancer-associated fibroblasts to better represent the real tumor microenvironment, with the hope that it will yield better results than the current models used in different labs. And then we tested the combination of gold nanoparticles as radiosensitizers, lipid nanoparticles as a second radiosensitizer, and as a drug carrier with radiotherapy. The goal here is, the idea is that any increase in survival, no matter how small it is, will hopefully save the lives of thousands of people all over the world. So no matter how deadly pancreatic cancer is, there are always people behind the scene who are trying to use unconventional ways to tackle this disease. So there's always hope. Thank you so much for listening.
Thank you very much for that very exciting research presentation. Do we have any questions from anyone in the audience, Divya?
We have one question from the audience, Diana. It is from an anonymous attendee, so I'll read it out. So, pancreatic cancer is best known for its stromal surrounding, which protects the tumor from being exposed to the chemodrugs. How is your therapeutic strategy going to overcome this challenge?
Yeah, that's an excellent question. Again, the size of these nanoparticles will definitely allow them to reach the tumor site, despite the complex and the very tight tumor microenvironment. We actually have done some in vivo experiments that shows the superiority of lipid nanoparticles compared to using the free drug docetaxel. The experiment is still undergoing, so I cannot reveal all the results right now, but hopefully in the future we will be able to publish papers based on these results.
All right, thank you. Would anyone else like to ask a question? If so, you can raise your hand or put your question in the chat. Divya?
Yeah, we have one other question, Diana. Could you kindly explain the various functionalization approaches for GNPs to target them to the tumor?
Yeah, so for our gold nanoparticles, we functionalize them with both PEG and RGD. So PEG in this case is used to help these nanoparticles avoid the immune system when they enter the system, when they enter the body. And RGD is used for targeting specifically. RGD has been shown to be overexpressed on certain types of cells, including pancreatic cells, pancreatic cancer cells, and cancer-associated fibroblasts of pancreatic origin. We're also looking for other better targeting effects, actually, or better targeting peptides to use to target tumor cells specifically.
Excellent, thank you. How did you decide what size of gold nanoparticles to use in your experiments, and what size did you ultimately settle on?
Yeah, so the size of the nanoparticles that we use is around 15 nanometer in diameter. And the reason behind that is that we have done multiple experiments, both in vivo and in vitro, using 2D and 3D models. And we have seen that this specific size has the better penetration capacity to reach the tumor as compared to like larger sizes or even smaller sizes. And they also like this size balances between the penetration capacity as well as the functionalization.
Great. I have a question about the 3D spheroid model that you mentioned representing the tumor environment. Is that a digital model or is it another model? And how reliable do you think that that will be if you transfer into human subjects in vivo studies?
Yeah, so in this model specifically, we try to use cells that are relevant to the real tumor microenvironment. So that's why this co-culture model, we added a new cell type, or not a new cell type, but a more relevant cell type, which is cancer-associated fibroblasts. Mm-hmm. Unfortunately, in a lot of different experiments currently, like in vitro, most labs focus on cancer cells and not other types that are also important in the tumor microenvironment. So that's why adding the cancer-associated fibroblast showed in our experiment that it did add extra resistance to the treatment. So that's why we're hoping that when we do more in vivo experiments, they will better match the in vitro work that we've done. And also 3D work or 3D models, again, show like, because it's in 3D, it will have a more real representation of the real 3D tumor microenvironment.
Oh, great, thank you. Are there any other questions, Divya?
One's come right in, Diana, right now. So it says, have you tried or do you intend to use 3D printed tumor-like environments? Would this be better than spheroids, in your opinion?
Yeah, that's an excellent question. Actually, before we tried the spheroids, we did try to use 3D bioprinted tumor models. We did run into a few problems there, mainly due to the size. The reason behind that is that we couldn't get into a size that does not introduce, what's the word I'm looking for here? Hypoxia. So we didn't want to add another factor right now that would complicate the model and would interfere with the results. But hopefully in the future, we would move on to 3D bioprinted models.
All right, thank you. So final invitation to ask a question of our first speaker today. Any additional questions or comments? All right. Thank you very much, Z. It's wonderful to see so many questions around your research. It's clearly very interesting, and the potential of this project is extremely exciting.